How about more skin in the game? That's the other one that's very popular for the laissez-faire approach. If we just had more skin in the game, we would all be better consumers. I always have the image of sitting in my doctor's office in my little hospital gown, in my little gown, paper gown, thinking about how much fun it is to have skin in the game in that way. But that's very much also the way it is. How many of us are thinking about, when we're in the midst of a healthcare crisis, having skin in the game? Another statistic you ought to understand is that no matter what your age, no matter what your not your circumstances, but let's just take any age slice, 18 to 24-year-olds, 65 to 85-year-olds, take a slice of that, and 5% of that population is accountable for 70% of all healthcare spending. I'm sorry, I misspoke. Not 70%, 40-some% of healthcare spending. 70% of people account for nothing or almost nothing. And as a consequence, what you have is this incredible maldistribution. And if you were in that 5%, accounting for 40% of healthcare spending, which is where the real bucks are if you want to save money, you are well beyond the notion of a co-insurance or a deductible changing the way your behavior is going to operate for the most part, unless it is so large that you can't afford it when you need it, which isn't necessarily a good case either. For the 70% who use very little health care, having a deductible isn't much of a deterrent either because they're not using health care. Also beware of people of all sorts of studies that tell you that 70% of the people are happy with their health care. Those are the folks who don't use it. Those are the folks who are perfectly happy because they only go to the doctor maybe once a year, if then, and they're not using health care, so that's something to keep in mind. As a society, one of the things we need to do about this, I believe, is make care available to everybody who needs it, and to make sure that we're getting good bang for our buck. That is, make sure that we really are getting the kind of care that is providing effective, useful services to individuals, and not simply the newest gee-whiz medication or gee-whiz piece of technology that comes along. If it truly is gee-whiz, then go for it. I think the country of Australia is very interesting in that regard. They have something that they call their prescription drug scheme, prescription benefit scheme, and by scheme they mean something different than Americans mean when we think of schemes. They mean plan. And their prescription drug plan, despite what you may have heard about it, essentially says we will cover all drugs that are necessary and effective, and if you want to be covered, come one, come all, and apply. And what happens is then when a manufacturer comes to them and says, we want you to cover our drug, they say, number one, show us that it's effective. And number two, if there's another drug like it, show it that is at least as good or better than that drug. And if it meets both of those criteria, then you can charge exactly the same amount as the other drug that is already there, and no more unless you can demonstrate that it truly is better or truly is something that is dramatically improved. Drug prices are dramatically lower there. A few years ago, a colleague of mine from Australia was here, and we were studying Medicare Part D together, and she discovered that most people pay out of pocket with Medicare Part D more than what is paid for drugs in Australia. But it's not the case, for example, that they don't pay a lot for certain drugs. Drugs that they believe are truly life-saving and unique, they sometimes pay more than we pay in the United States. They do it on the basis of value and getting value for your dollars and requiring studies. Also, when you hear someone say, well, we can't compare drugs in the United States because we don't know which statins are better than each other, the Lipitors and the Crestors, not true. If they want to participate in Australia, they have to do head-to-head trials, and those exist, but they're not allowed to tell us because of our trade laws. We negotiated to protect American manufacturers' trade laws that say that the Australians cannot tell us which drugs work better than others. because that's a proprietary piece of information. Sad but true. We have a lot of things that we can do to improve health care in the United States. This health reform program, I think, will make some major improvements in those regards. Leaves a lot of things on the table. But let me talk about the Medicare aspects of it, because that's where some of the things I've actually been talking about will take place. Medicare's role in the healthcare reform was largely to step aside but make available substantial amounts of savings that could help us afford health care for the rest of the population, which has caused a lot of people a lot of heartburn. But let me talk about some of the good things about this. First of all, there were modest improvements made in the Medicare program. There would have been more and better ones if the House bill had passed. But we will see a gradual elimination of the donut hole in the Medicare drug benefit. And I know most of you have drug coverage through FEHB plans, so it's not useful to you, but if you know people who do have that, eventually the donut hole, which is the gap in coverage that occurs where after the first initial coverage ends and before catastrophic picks up, there's a period where you got a lot of skin in the game, 100%. Essentially, you don't get any coverage from the insurance companies. That will gradually go away. It'll take a long time, but it will go away. That's an improvement. And preventive services have been improved in the Medicare program. No longer will there be copays. No longer will the deductible apply for most preventive services, including an annual wellness visit. So those are improvements, and those are improvements in the right direction of how we'd like to see healthcare change, to emphasize wellness as opposed to sickness in many cases. But those are the major things that are changing, that are improving the Medicare program directly. The other things that are sources of financing for reform are substantial changes, $500+ billion. That's a lot of money, and it should be of some concern, but of less concern than some people would wring their hands and tell you. The first piece that will affect beneficiaries is one that affects Medicare Advantage. That's the private plan option that people sign up for and say, I don't want traditional Medicare, I want to be in a private plan. And again, for most of you, I know that's not relevant because you don't have to do that. You can, if you're going to do that, you sign up in a different way and don't go into those private plans. But those private plans were traditionally paid in the range of 14% more on average than it would have cost if those people had stayed in traditional Medicare. In 2003, to try to make competition work, the feeling was if we got people into private plans, then this was some people's feeling, not mine, but then healthcare costs would come down over time in Medicare. And to encourage private plans, the thought was you had to lure them back into the market because before they had been cut back, and that you had to pay them more. They were paid substantially more, and that was supposed to kind of gradually go away with competition. Never went away. As a consequence, that 14% meant that a small number of people, and growing up to about a quarter of all beneficiaries who were signing up for Medicare Advantage over time, largely because of these extra benefits, were getting extra benefits. Not the full amount of the 14%, which is over $1,000. They weren't getting $1,000 worth of extra benefits. That was going someplace else. But they were getting extra benefits, and it was appealing to sign up. It also meant that for all of you paying Part B premiums, if you do, then you were paying higher premiums because you were helping to subsidize that 25% of the population that was in those plans. There's a substantial cutback, scale back over time in how much those plans will be paid. Not all the way back to full parity, but getting pretty close. And I think that makes sense. Why not have a level playing field and say you can choose traditional Medicare, you can choose a private plan, but the private plan should not be subsidized. That's about $130 billion, give or take a few billion dollars. So that's a big chunk of those savings. That's caused a lot of people to say that their Medicare Advantage plans are being cut back and they're losing benefits, and they are. They're some of the losers in health reform. But they were getting a windfall gain before. It's a little bit like closing a tax loophole. I don't feel so sorry for those folks because they were getting a lot of good benefits for a while. And if they're in a good plan will still do a good job for them over time. The second area that will affect beneficiaries where cuts were made was in expanding the income-related premiums that now exist in the Medicare program. If you are in Part B and you pay a monthly premium and have a substantial income, you will have to pay a higher premium because of that. As an individual, income above $85,000 a year, it gradually increases over time and reduces the amount that Part B is essentially subsidized for you. The Part B premium for most people pays 25% of the costs of Part B, and that income-related premium takes that percentage up over time. And it's $170,000 for couples. So what happened is that threshold normally would rise over time as people's incomes rise on average. So the next year would be $87,000 as a cutoff, and then $89,000 and so forth. What this legislation did was, for a period of time, freeze that at $85,000. And so it means more people will be affected by it over time. About 3.5 million people by 2019 will be affected by that, because more people, their incomes will rise a little bit, but the threshold will not, and therefore more people will be considered high income. Remember, you're only high income if you're above $250,000 when you're paying income taxes, so you've got to think about how that all works out as well. The other thing that happened is that a premium was then added, an income-related premium, to Part D, which had not been there, that follows the same rules. So for a number of individuals, they will be paying substantially higher premiums over time, a lower benefit. So when people tell you that we should make sure that high-income beneficiaries pay more over time, they already are. And that has been changed several times now to increase the number of people who are paying substantially more. Now, the bigger changes, however, that's only about $30-some billion. And I say only in terms of when we're talking trillions in the healthcare world. The other big changes will mean slower growth in payments for providers. And before you get very excited about that, then think about that over time we are going to have to find ways to pay less to the providers of healthcare. And our hope is that we make them be more efficient. And traditionally, that's what Medicare has done over time and has been quite successful. The changes that came in early on in the 1980s led to a lot of changes in hospital care, some of it getting people out sooner probably than it would have been desirable for, but not that much sooner. And hospitals became a lot more efficient places. They're not quite as nice as they used to be. You don't get as much attention from nurses as you used to, and some of that may be going a little too far, but we pushed on hospitals, and hospitals have become substantially more efficient. These cuts are very much in the same kind of vein and in the same order of magnitude of those kinds of changes in the past. And they pretty much affect all providers of services with the exception of doctors, because doctors have been pulling these things in. Have been subject to substantial cuts over time, and they are pretty much protected from this. So my message here, my bottom line, is that these things are working in a reasonable way. There's no reason to be incredibly concerned about the Medicare program. It is going to be okay going forward, and it is going to be a key part of our healthcare system, I believe. I hope that when people start to talk about entitlement reforms, they don't pile on to Medicare, because Medicare has given. Unfortunately, I think it has given for a pretty good cause, and that is to improve the healthcare system for everyone else. That will have dividends and pay benefits. For example, we're going to pay less to hospitals over time under the Medicare program, but hospitals are going to get benefits from having fewer uninsured people come to their doors. So there are going to be a lot of changes. There's going to be a lot of hand-wringing, but I think we're going to be moving towards an improved healthcare system if we stay the course and make rational decisions as we move forward. Thank you very much.